Top Med Talk.
Nick Majerison here. From October the 8th to the 12th, it's all about Dingle on Top Med Talk. Evidence-based perioperative medicine, EBPOM, is proud to present the 21st current controversies in anaesthesia and perioperative medicine and the SIAA Autumn Congress. Check out ebpom.org/meetings to find out more. Then, from October the 19th through to the 23rd, it's Anaesthesiology 2019, the annual gathering of the American Society of Anesthesiologists in Orlando, Florida this year. Top Med Talk will be covering the conference from day one with live streaming of our conversations from the booth and unique content. Check out our website for more details, www.topmedtalk.com. That's www.topmedtalk.com.
Hi, I'm Desiree Chappell. Welcome to Top Med Talk. It's Tuesday and it's time for my Roundtable. The Roundtable is a chance to sit down with a multidisciplinary group to have discussion about perioperative care and improving the quality of what we do every day.
Top Med Talk.
All right, my name is Desiree Chappell, the host of Top Med Talk, and I'm here with Joff, Lacey, my co-host as well. And we are at the Royal College of Anaesthetists Anaesthesia 2018, and we're sitting down after our lunch today with two of our speakers. We have Dr. Mark Edwards. He's a consultant in anesthesia and perioperative medicine at the University Hospital Southampton. And we also have Professor Gerard or Jerry Danjoux, consultant in anesthesia and sleep medicine at the South Keys Hospital. Thank you, gentlemen, so much for joining us and sitting down with us to discuss.
Thanks for having us. Delighted to be here.
This is a great first meeting so far. We've had some really good conversations, and I really enjoyed your presentations today. So we can just jump right into it. Mark, today you were talking about why patients have adverse outcomes, and you dove a little bit into what are the adverse outcomes that we're looking at, and kind of those versus experiences of patients and things like that. Can you talk a little bit first about your background, what you've been doing? Yeah, and then dive in.
Okay, sure. So I guess I've got a mixed background in terms of clinical practice. I'm an anaesthetist for major adult surgery. We also do some non-theatre-based work, so I do quite a lot of preoperative assessment, some exercise testing and so on. But also working on clinical services. We've got a big interest in developing perioperative medicine services down in Southampton, led by Mike Grocott, and actually now Denny Levitt's taking over that piece of work. So a great team down there looking at the pathway and our local outcomes to improve. I'm also research active, so I'm involved in clinical trials, leading a large clinical trial called FLOELA, which is around perioperative cardiac output monitoring and fluid algorithms for patients undergoing emergency laparotomy surgery. So
yeah, we hope to be talking about that later today,
for
sure. Yeah. Oh, that's great. So just diving right in, when we were talking about what the adverse outcomes are for the perioperative surgical patient, what have you been doing in that? And give us a little bit of background about what you talked about today.
Yeah, so I think I wanted to look at this at a few levels, really. And I think one of the things that was important to highlight was the lack of universal definitions that have been out there. And I think poor outcomes are something that everyone has this sense, this feeling are important. I think people appreciate the global impact, really, of people doing badly after surgery. But it's really hard to kind of attack that problem if everyone describes it in a different way. And the literature that's been going in this area for years and years, everyone's decided on their own definition of a post-operative complication. It's been really hard to group data together to do evidence syntheses. It's been really hard to get consistent messages about what really matters. What are the outcomes that seem to be the most important ones? Because it's like the goalposts keep changing. So what I sort of was highlighting that there was a lot of good work. I mean, there's been interest in looking at more structured survey systems like the post-operative morbidity survey or PROMS, ways of structuring the severity grading of complications with things like the Clavian-Dindo system. But more recently, there's been a huge amount of work done by Paul Miles and a huge international group going through reported outcomes in the literature in a systematic way having a Delphi process to refine that down and using sort of expert groups in their individual areas, things like pulmonary complications, patient comfort, those sorts of things, to actually come up with some consensus on how we should be describing post-operative morbidity. And those papers are actually just starting to come out through the BJA now, and they're great pieces of work that we certainly recommend people look up. The STEP Compact groups work on those.
Yeah. So one of the things that we talked about was describing outcomes in a clinical way, how we as providers talk about them. But one of the things that's not really talked about or is becoming more of a popular topic is the experience of the patient and how they are reporting their own outcomes. And is that something that you've been looking at? And
yes, I mean, it's really important. It's kind of another aspect. We need these things to go alongside each other. We need to have a meeting of where clinicians' views on what makes a complication is also complemented by the patient perspective. So how are they reporting outcomes? So there's PROMS, patient-reported outcome measures, but also what their experience of care is like, which is a kind of a different dimension on things, but it's so important as well. And they don't always relate to each other. So your patient-reported outcomes don't always map against how satisfied and how good an experience people have had during their healthcare. So that's important. And also, as the Compact group have been doing, to also involve stakeholders and patients in deciding which are the kind of core outcomes that we should be looking at in research and in quality improvement projects as we go forward.
Yeah. One of the things that you mentioned today, too, during your presentation was talking about the pathology of adverse outcomes and what can contribute to that. And you were talking about chronic inflammation and how patients that actually show up to surgery in this state are at higher risk for having post-op issues. We talk about pre-op optimization, and Jerry, I want to bring you into the conversation here and tell us a little bit about what your work is with prehabilitation, what that actually means, and how we're using that maybe to talk about this chronic inflammatory process that's happening with our surgical patients. So Jerry, thank you for coming on. Will you give us a little bit about your background?
Yeah, I'm a consultant in anaesthesia and sleep medicine at James Cook University Hospital in Middlesbrough. Been there since 2002. I share a lot of common interests with Mark, and that I've got an interest in high-risk surgery, exercise testing, and evaluating risk. But in my more recent past, I suppose, I've done some research looking at exercise programs for improving fitness, and we've now translated that into more multimodal lifestyle interventions, so to address smoking, alcohol consumption, weight management, but also exercise in a kind of quality improvement implementation of a new model of care. And interestingly, what you're alluding to is this state of chronic inflammation. A lot of our unhealthy lifestyle behaviors, if you like, are thought to lead to this state of chronic inflammation, which the end product is kind of disease, chronic health conditions. And interestingly, some of the more recent thoughts around exercise is that it is an anti-inflammatory. So you can see where that might come from.
Yeah,
well, just to kind of fill in some of the gaps there, Mark, if you could explain, you showed a very interesting slide on that where which showed the gene transcription for those patients that suffered complications, those that didn't, and how it changed throughout their perioperative pathway.
Sure, yeah. So that was an interesting study by Zhao in the Journal of Experimental Medicine, and it was really, this is less about, I guess, the pre-insult phenotype and more about what is the systemic response to a kind of a tissue injury. They looked at a mixture of insults like burns or severe blunt trauma. And what they saw, really, they looked at gene transcription patterns across within leukocytes, and it was really dramatic that the changes that happen, almost 80% of gene transcription changes in response to those kind of insults. And interestingly, even though conventionally, I guess, within critical illness, we've seen or we've heard about the SIRS response, systemic inflammatory response syndrome, it's big peak of inflammation, which can be life-threatening itself, which then wanes away and then is followed by a sort of system of immune suppression. which then makes people much more susceptible to kind of low-level pathogens, and that's how they get this kind of second hit and so on. They were challenging that model. They said, look, actually we can see these changes happening simultaneously. So we get changes which would lead to a state of relatively suppressed immune cell function at the same time as we're seeing this kind of pro-inflammatory burst as well. So the whole kind of spectrum is changing. But that actually the pattern in which that happens seems really kind of stereotyped. So across types of insult, that seems to be a consistent pattern. And it also, the actual pattern of it appeared similar between patients who had an uneventful recovery from that insult as compared with patients who had a much more difficult time, had complications, and had poor clinical outcomes. The pattern of change was very similar. What was different was the magnitude of change was much greater in the sort of the disordered patients with complications, and also the duration was much longer, and they could still see gene transcription changes 28 days after the original insult in patients with with a complicated recovery from that.
That's interesting, because if you look at how that maps against the slide I put up as to how prehabilitation is kind of designed to increase your buffer, if you like, of activity and dependency leading up to surgery, and this melee of, things that go on around the time of the surgical insult cause the drop in independency and then the recovery period. So that fits in really nicely with that kind of model that, we also see in frailty, for example, in people who just get a flu insult or something.
Yeah.
It's a very similar translatable model. It's just the insult here happens to be surgery.
Yeah.
So it's not just the say obvious benefits, the cardiorespiratory benefits of exercise. Is actually placing the patient in the optimal inflammatory state preoperatively, so that they don't get as marked as once.
I mean, we don't have that level of evidence. That's the theory.
Yeah.
But that is exactly where we're coming from. That addressing these unhealthy lifestyle behaviours, optimising chronic health, is going to have its own anti-inflammatory effect leading up to surgery, as well as other, hopefully, longer-term benefits from a public health perspective. So,
I mean, I think the persistent inflammation thing after surgery might be a real, plausible explanation for why we see in-hospital morbidity mapping so well to long-term mortality, long-term illness. There's this thing that I showed about people being much more prone to deep vein thrombosis for weeks and months after even quite minor surgery. So what's going on there? What's been set in motion? And again, I mean, there could be other mechanisms. It's a theory. It's hypothesis generating, but it's quite plausible that actually there's a degree of chronic inflammation there which is driving ongoing processes. And if you don't have the reserve to kind of deal with those, perhaps you then get into a vicious cycle around reduced activity, more of a sort of an unhelpful physiological status, and that kind of catches up with you.
I think that's one of the most stark messages from a lot of both of your slides in your talks, is actually just quite how persistent the effect of the adverse outcome is. You think that they had a bit of a bump in the first week of recovery, and but objectively you think they may well have actually recovered, but actually more and more data showing that for months and months
up to
afterwards,
6 months,
then there are issues.
I mean, the Sentinel paper of the early work was by the Curie study that you showed, showing that you have one complication, you get discharged, your life expectancy is reduced against age match or case match patients who don't have complications, your life expectancy reduced for years afterwards.
Crazy, yeah.
And that's really important. That was Sentinel early work by that group.
Yeah.
I liked what you said about what we were finding from Paul Miles' relief trial. 14% of persistent disability for years after without pre-existing.
Yeah, no, absolutely.
Conditions.
So I think, I didn't obviously go into the kind of the clinical outcomes of one arm of that trial versus the other, but it was an important message, I think, and it's great work that, Paul and that team have done on looking at what are good outcome measures in trials that can integrate not just whether you're alive or dead, but actually what's life like, because what really matters to patients. And, anecdotally, we talk to patients in our clinic, we say, look, I'm worried about this. You could die as a result of having this surgery. And people seem often less worried about that than when you say things like, but also you know that actually you might not be back on your feet after 6 months. You might be a bit more dependent on your relatives and carers if things go badly after surgery. That seems to be the sort of the message that was not coming across before, which I think is important, and that needs to be out there, I think.
No, I agree with that, having done shared decision-making models for a number of years in pre-assessment. And I agree that patients are far more interested and focused around the longer-term effects. Can they get back to what is a meaningful quality of life, physical activity for them? It might just be walking down to the shop, it may be cutting the grass, whatever it happens to be. They want to know that they're going to be able to have a high chance of getting back to that quality of life, and that's really important to them.
Yeah, and so one of the pieces that I love to bring up whenever I'm talking to people that are kind of doing the evidence themselves and or the research themselves is how we translate that into everyday practice. And that was a great example, Mark, of talking to patients. But Jerry, you mentioned Prep Well, or one of the So can you tell us about that initiative and how that's working on the ground?
Yeah, so Prep Well is a health and well-being program, which we've modelled on cardiac rehabilitation, and we've integrated with the leads from cardiac rehabilitation at York University. And basically what we've done is transposed core elements of their model to the preoperative setting. And we're taking patients as early as possible who have evidence of unhealthy lifestyle behaviours. They're inactive, they smoke, they drink more than government recommended unit, or the healthcare professionals just feel they would benefit from prehabilitation. And they come into the program. It's community-based, and it's run by Esther Carr, who's our project manager. She's an ex-cardiac rehab physiotherapist. And Esther works with the health trainers at the gym, and we're providing a one-stop facility for a minimum of 4 to 6 weeks, pre-surgery, where patients come in, they have supervised exercise twice a week, but they also have one-stop access under the same roof to smoking cessation, alcohol reduction and nutritional support. And we're also providing psychological support. Esther is also a yoga instructor and is into mindfulness.
Fantastic.
So we're able to offer kind of mindfulness support for patients preoperatively. And we've got expedited diagnostics for patients who are suspected of having problems like obstructive sleep apnea. Obviously that ties in with my interest in sleep medicine.
Yeah.
That's known to be a cause for concern with surgery and adverse outcome. So traditionally, if somebody you thought at pre-op assessment had OSA, they may have ultimately a delay of up to 6 months before they could have their non-cancer or non-urgent surgery. We're able to do a diagnostic from the original entry evaluation and get patients on CPAP within 2 weeks. So that's cut a huge swathe of time out of that pathway.
Oh, that's fantastic.
Can I just ask you, so the program's 4 to 6 weeks?
It's a minimum of 4 to 6 weeks.
And I know many people listening will say, well, a lot of my patients are cancer patients. There's an expedited patient pathway.
Yeah.
Can you make a difference in those 4 to 6 weeks? Does the evidence show that you can do enough to... well, maybe not the evidence to say if it improves outcome or not, but certainly can we improve cardiorespiratory fitness in that time?
So yeah, I was asked this question at the end of the talk, and it is patient-specific, population-specific, but the minimum time period that is thought to be effective is 4 weeks. But the important thing is the major benefits are made from being sedentary to mildly or moderately active. Right. So we're not trying to turn people into a Froome or a Wiggins here, however that might be done. We're trying to get people to do some activity from not doing anything before. And that seems to be where the biggest benefits are accrued.
Avoiding the sedentary lifestyle as opposed to...
Is it for all surgical patients? Like, what is is there a specific patient population that this works the best for, or can this be generalized for the entire surgical population?
So to start with, within PrepWell, we're targeting more complex or major surgical procedures because the risk of an adverse outcome is higher in those groups. But we've also, excitingly, got a grant from Sports England, and we're looking to scale this project up locally so that it's available on a stratified pathway to different patient groups. So not everybody will want to come to a gym before surgery. Yeah. So there may be park walks, there may be just use of green spaces and other things. And I'm working with public health representatives locally to really broaden this out across the local area. So we're really excited about that opportunity as well.
Yeah, Mark.
Can I just ask, Jerry? I mean, I think exercise feels like it's got to this stage, as a lot of things do, where there's a huge amount of interest on the ground. And, for years I've had sort of, surgeons saying, we should exercise these patients, that sort of thing. So there's obviously a great kind of willingness on the ground to actually try and do it. Where do you think, how do we make that interest and that kind of motivation to engage in these sorts of programs work with also building the evidence base? Because obviously I work in Southampton with a team that are very engaged in still looking at kind of randomising patients to one arm or the other and just seeing if we can kind of build up that evidence base to support it as an intervention. But obviously, meanwhile, there is interest elsewhere in actually, look, let's just get on and do it. Let's package it with some other interventions we think. How do we make that work together for everyone, do you think?
Well, I think, from the model you've described in the Wessex, the WesFit project that Mike and Sandy Jag are running. My understanding is that they've got two arms to that. There's also an implementation arm to that they're working with NHS England on. So that's a really positive way to do it. I think it is important. We are aware that there's large clinical trials going on in colorectal surgery, Prepare ABC. There's also a pan-European study going on. So it is important to use the outcomes. But I think in tandem with that, it is important to also have clinical implementation projects, because we all know scenarios where you've got a strong evidence base, but translating that into clinical practice is a challenge. And through the implementation work we're doing, we're also supporting that with an evidence base. But I think the two have to go hand in hand, so that when we reach the tipping point, if you like, everything does have a tipping point, and I hope we're getting there soon, that there's evidence that patients will engage and they'll come along from the implementation work. But at the same time, the evidence base grows from all of the other larger studies that are going on, and then we're able to almost make an overwhelming case that this is a good thing to do on a much larger translational scale.
Yeah, well, so kind of wrapping it up, that's one of the messages that we're hearing now, is that we have to do those in tandem to really, get the evidence base there, but also be able to apply it on every day. Because it doesn't matter, we can have all the evidence in the world, but if we're not using it in practice, it really, and people revert to dogma, it doesn't. It's
kind of a bit
much.
like action research.
Yeah.
So, you can have different models of research, and building action research into your implementation work is one way of actually doing that.
Yeah. No, that's great. Thank you so much. Jerry, can you give us an idea for the listeners where they can visit the PrepWell site? Because I know a lot of people love to have models to be able to use in their own practice. So.
Yeah, so there's some details in the Royal College of Anaesthetists bulletin from March about PrepWell. For anybody interested in the GP toolkit, that's available at prepwell.co.uk. And if they go into Google and put South Tees PrepWell, they'll find some more information about the project on the hospital website.
Great. Well, gentlemen, thank you so much for sitting down with us. We're going to head back into the next session. Thank you so much.
Thank you very much.
Thank you.
Top Med Talk.
Nate Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.